Okay, so let's begin this section of the program on practical considerations for the quantification of pain. Let's begin this section with a simple question. Let me ask you, is it possible for us as examiners and evaluators to be able to understand what and how our examinee is feeling in their physical body? Is it possible for us to be able to tell what they're feeling inside their physical body? Let me ask you. How would you respond to that question? Well, there's probably two answers to that question. The truthful answer is that no, it's not possible for us to feel another person's pain. In other words, you can't feel my pain, I can't feel your pain. And it's not possible for us to really fully understand what and how our examinee is feeling. For those very reasons, you cannot step inside your examinee's body and feel what they feel. And isn't that what examinees try to convey to us? They try to convey to us their feelings. And you may have some experience with this yourself. If you put yourself in a position or go back in time when you've ever yourself have felt pain, isn't it true that you just want another person, for example, your loved ones, your spouse, your significant other, your kids, you just want that other person to feel what you're feeling. And so we use all these different types of descriptions to convey to the other party what it is we're feeling. And many times they simply nod their head, or they agree with us, or they say, oh, that's terrible. But they never really give us the satisfaction of being able to feel what we're feeling. In fact, there's a quote on the AMA guides on page 566. It says, to have great pain is to have certainty. To hear that another has pain is to have doubt. And isn't that the way it is with our qualified medical evaluations? We sit in front of the examinee as they talk about their certain pain. Their certain pain, and they're certain that they have pain. And yet many times, because we can't feel the pain or experience what they're feeling, we have great doubt. So the answer to this question is, on the one hand, is no. But on the other hand, there's a yes answer to the question as well. And that is that even though we can't feel what they're feeling, we can't feel the pain that they're experiencing, and there's no way for us to live inside their body and feel what they're feeling, we can sometimes quantify the pain by observing how the pain that they're having impacts their ability to perform activity. And in the AMA guides, we refer to this as activities of daily living. So let me give you an example. Let's imagine that you're watching a sports game, like a basketball game, and you've probably even seen this happen before many times. You're watching a sports game, a basketball game, and one of the basketball players has a terrific collision, and he falls to the floor. And the camera zooms in on him, and he's seen on the floor writhing in pain. And we can tell that he's having great pain. Well, how do we know whether or not he's faking that pain or whether that pain is actual? Well, we confirm that it's actual pain when the basketball player gets up to his feet and with great difficulty, he limps off the floor, or he limps around the floor trying to so-called walk off the pain. And we can see that he can barely bear weight on one of his lower extremities, and there's a terrific limp, and it's this terrific limp that gives us an indication that indeed the pain that the basketball player is suffering in the moment, the pain greatly affects his physical function and greatly affects, in this case, his ability to bear weight, his ability to walk, and his ability to perform his duties as a basketball player. So by looking at the impact of the pain on activity, and specifically on activities of daily living in the AMA guides and in our qualified medical evaluations, We look to see how the pain interferes with activity in the physical examination that gives us an idea as to the true severity of the pain, and it allows us some measure to be able to quantify pain. So let's talk about a little bit about pain. Let's define pain, and then let's go into a practical assessment for the quantification of pain using both references, old and new. So let's begin by defining pain. The International Association for the Study of Pain describes or defines pain as an unpleasant sensory and emotional experience arising from actual or potential tissue damage, or described in terms of such damage. It's an unpleasant sensory experience, and it's an unpleasant emotional experience. And we'll elaborate on some aspects of the emotional experience here in just a couple of minutes. Well, the American Academy of Pain Management has slightly modified the definition to consider more of the emotional aspect. They define pain as an unpleasant sensation and the resulting emotional response to that sensation. On page 566 of the AMA guides, they adopt pretty much the definition of the International Association for the Study of Pain. They describe pain as an unpleasant sensory and emotional experience associated with actual tissue damage or potential tissue damage. So the question is, where is the sensory perception of pain picked up? Well, of course, it's picked up in the periphery. It's picked up in the periphery through a series of specialized nerve endings that inform the central nervous system about tissue damage, about pressure, about light touch, about vibration, about hot, about cold. It's picked up in the it's picked up in the periphery through a series of specialized sensory receptors, and we'll talk about those here in just a few minutes. So where is the emotional perception of pain picked up? Well, the emotional perception of pain is picked up not in the periphery, but centrally in the mind. It's the mind where the repository of experience of prior past associations with pain, prior events of tissue damage, and prior memories of painful experiences are all stored. The emotional experience is a complex interaction that takes place in the mind. And I'm sure you've heard it said many times that people are a certain mix of both logic and emotion. And I remember one time I was listening to a Zig Ziglar presentation on selling. And I remember Zig Ziglar talking about the proper mix of the sales presentation, the proper mixing of logic with emotion in the selling process. And I remember Zig Ziglar saying that people are 80% emotional and 20% logical. And you've probably heard these different ratios quoted. People are 80-20 logical to emotion, or 90-10 emotional to logic. Well, I recently heard a psychologist use a different set of numbers, and he said that people are 100% emotional, 100% emotional. And their logic later on, after the emotional response has faded, their logic becomes construed to justify the emotion. Isn't that interesting? People are 100% emotional. They react 100% emotionally, and later they justify their emotion by construing, or maybe even misconstruing, their logic to fit and to be consistent and commensurate with the emotional reaction. So we're going to be dealing with people and their emotional reactions more so than we're dealing with actual sensory perception of pain due to actual tissue damage in the periphery. And this is going to be important to keep in mind as we go through some of these ideas related to practically quantifying pain, and as we go through some of the topics associated with malingering. And that is, we're mostly dealing with people and their emotional reactions to actual tissue damage or what they perceive to be as the potential for tissue damage. Okay, well, let's go through another definition. This one's right out of Merriam-Webster, and this is one that we're going to rely on throughout today's program. Merriam-Webster says that pain is a localized physical suffering associated with a body disorder, such as in a disease or an injury. Pain is a basic bodily sensation induced by a noxious stimulus received by naked nerve endings characterized by physical discomfort such as pricking, throbbing, aching, numbness, tingling, burning, and these are all the discomforts that our examinees are going to describe to us using their words, and they'll use a myriad of words to describe the physical discomfort. And here's the key component of the definition. Merriam-Webster says, and pain is typically characterized or typically leads to what they refer to as quote-unquote evasive action. Evasive action. And what is the purpose of evasive action? Well, the purpose of evasive action is to get away from, to evade the noxious stimulus, to evade the physical suffering, to avoid or evade the bodily disorders such as an injury. And we're going to rely on the presence or absence of evasive action as one of our milestones and landmarks to help us characterize or quantify the level of pain that an examinee reports. Evasive action is going to be one of those key observations that we are going to be keenly attuned to observe for as we go through our interview with the examinee, and certainly as we go through our physical examination with the examinee. So let's talk a little bit about evasive action. I want to now, at this point in the program, I want to introduce a couple of key components of objective findings. And I want to talk to you about what constitutes a true objective finding. And we'll go through some references in the AMA guides where the AMA guides talk specifically in the spine chapter about truly objective findings. And the phrase truly objective findings is to be differentiated from the phrase simply objective findings. We're going to see as we go throughout today's program, and I want to introduce the topic to you right now, that true objective findings are characterized by some form of evasive action. And I'm sure you're familiar with this phenomenon. And let me provide you a familiar example of the evasive action in the physical examination. I want you to remember back to your training on physical examination or your training in orthopedics, where you learned about shoulder dislocations. And if you remember about shoulder dislocations or shoulder subluxations, you learned some physical examination maneuvers known as the shoulder apprehension sign or the shoulder apprehension test. And there are many different apprehension tests. We also have patellar apprehension tests and other apprehension tests as well. In fact, most physical examination maneuvers result in some form of apprehension when the condition is truly present. Okay? So with regards to shoulder apprehension testing, we take the shoulder through a series of ranges of motion, and when the examinee suspects that the shoulder could possibly sublux or dislocate, they get a certain feeling in their shoulder that this could happen. And through reflexive action, the examinee will demonstrate what's known as the apprehension sign. Now, the apprehension sign is a form of evasive action. The apprehension sign is not something that the examinee says to you verbally. It's something that the examinee demonstrates to you reflexively by evasive action. And what the examinee will do when they sense a pending subluxation or dislocation of the shoulder, and this is completely reflexive, it's not conscious. What the examinee will do is the examinee will wiggle or wriggle or position themselves in such a way as to reduce the pending dislocation. They will maneuver their torso, they will maneuver their upper arm bone, they will maneuver their scapula, they will maneuver their humerus bone, they will withdraw, they will torque, they will contort in such a way as to reduce the possibility of a bodily disorder, such as an injury. They will wriggle so as to reduce the physical discomfort. They will wriggle in an evasive action to prevent the potential subluxation or dislocation of the shoulder. The same phenomenon takes place with patellar apprehension. The examinee will wriggle or will contract their quadricep muscles in such a way to prevent subluxation or dislocation of the patella. It's a form of evasive action, and we're going to rely on this definition of pain as we go throughout the remainder of the program. And here's a heads up for one of the themes of today's program, and that is, with regards to your physical examination, always be on the alert for evasive action. Another form of evasive action, and this is described in the AMA guides, again with regards to shoulder apprehension, they talk about muscular defense. Muscular defense against the motion. Muscular defense is simply another form of evasive action. And really, these different types of physical examination findings, whether we refer to it as evasive action or we refer to it as muscular defense, these are all forms of the flexor withdrawal reflex. And if you go all the way back to neurophysiology classes in your doctorate training, you remember that the flexor withdrawal reflex is a withdrawal from a painful stimulus. And the examination that's usually given in neurophys class is touching the finger to a hot stove or perhaps stepping on a sharp tack that punctures the skin. In either case, there's a withdrawal, and it's reflexive. It's reflexive. There's a withdrawal from the painful stimulus. It's known as the flexor withdrawal reflex. Well, truly positive objective findings all contain some component of the flexor withdrawal reflex. It's a form of evasive action. The flexor withdrawal reflex is evasive action from the hot stove or from the painful tack. So always be on the lookout for the evasive action or for various forms of the flexor withdrawal reflex. Okay, so with this as background material, how can we attempt to quantify the pain and the reports of pain that injured workers give us? Well, let's continue to develop this theme that probably the very best way is to try to determine how the pain impacts the ability to perform activities. And this is consistent with the AMA guides. And I want to sort of marry marry some of the concepts in the 5th edition AMA guides with the 2001 Physician's Guide, which was our Bible with regards to the 1997 Permanent Disability Rating Schedule. Both of these sources, the 2001 Physician's Guide and the AMA guides, are both very concerned with pain and the impact of the pain on activities of daily living. So let's take a look now at the 2001 Physician's Guide. Well, the 2001 Physician's Guide, which was our Bible of procedures for qualified medical evaluations prior to the adoption of the AMA Guide's 5th edition, the 2001 Physician's Guide had some fabulous discussions, or I should say has some fabulous discussions on pain. And the 2001 Physician's Guide sort of categorized pain into 4 basic categories. They quantified pain as either a minimal pain, a slight pain, a moderate pain, or a severe pain. So we'll talk about the 2001 Physician's Guide here in just a minute. What about the AMA guides? What do the AMA guides say? Well, the AMA guides say on page 566, and I seem to have lost my graphic on this, so I'll simply read from the reference on page 566. The AMA guides say that pain is subjective. Its presence cannot be readily validated or objectively measured. Physicians, therefore, are confronted with ambiguity as they attempt to assess the severity and significance of chronic pain in their patients. So, how can we do it? How can we quantify the impact of the pain on activities? How can we quantify the level of pain that our examinees describe to us? Well, let's go through first what the 2001 Physician's Guide has to say about pain. They talk about 4 levels of pain. Again, it's minimal pain, slight pain, moderate pain, and severe pain. And as we're going to see, we need to keep these definitions, once we define these in just a minute, we need to keep these definitions in mind as we go through all components of the qualified medical evaluation. When the examinee is in the interview process and they're talking about their pain, we need to always keep in mind and always translate their descriptions of pain into one of these 4 categories. Is it minimal pain? Are they describing slight pain? Is what they're talking about, does it qualify as moderate pain, etc.? When we go through the physical exam, we need to determine and decide to ourselves first, is this an example of minimal pain? Is it slight pain? Is it moderate pain? And these decisions will be very clear and very easy to make once we define what each of these pains represents. Okay, so areas where we need to keep these definitions of pain in mind occur in the physical exam, occur during the activities of daily living assessment, occur during our decision making when it comes to providing for work restrictions and work preclusions, and also when we consider the social history or the examinee's social life. We need to take a look at how, or even if, the pain is interfering with their ability to carry on their social responsibilities and their social life and social duties. Okay, so let's define these here one by one. Okay, so the first level of pain is minimal pain. Minimal pain. Now, by definition, and this is right from the 2001 Physician's Guide, a minimal pain is a pain that has no handicap in the performance of the activity. So, what is the activity? What is the activity? Let me give you an example here. In this diagram, in this PowerPoint presentation, we have a photo here of LeBron James. And this is from the 2015 NBA Championships. And you remember LeBron James, he took a hard fall in one of the later games, like Game 4, maybe Game 4, Game 5. and he suffered a cut to his head. And here is the cut in his head. It's now stopped bleeding, but it was a big deal when he had that cut on his head. Well, certainly the pain in his head and on his scalp at the time from this laceration was profound pain. But once they put compression on the cut and the bleeding was slowed and stopped, the king, as they call him, LeBron James, went back out on the floor, played some fabulous basketball, scored a huge number of points, and was generally ferocious out on the court. So in that sense, the pain that he was feeling in his scalp, and this could refer to pain anywhere in the body, whether it be lumbar spine, shoulder, temporomandibular joint. In this case, we're using the pain in the scalp as a metaphor. The pain in his scalp was a minimal pain because the pain in the scalp did not interfere with his ability to be an effective basketball player. He ran, he shot the ball, he blocked shots, he rebounded, he ran plays. The pain in his scalp had no impact on his ability to perform as a basketball player. Now, the pain in his scalp may have been a different type of pain depending upon a different type of activity. So, for example, if we're talking about the activity of scratching your head or getting a massage to the scalp, it could be that that pain in the scalp would prevent scratching in that area of the lacerated scalp. It could prevent massage being administered to that area of the scalp. So depending upon the activity, the level or description of pain can be modified or can be different. But in this example, when we're talking about playing basketball, the pain was a minimal pain because the pain did not interfere with the activity. Let's talk about another example. How many of you like to go to the health club and work out on the weight machines or with free weights? Well, if you spend any time at the health club working out on weights, you've probably seen people who put the weights down from their set of exercise and will take their shoulder or will take their arm and rotate it around in the shoulder as they hold the shoulder with one hand. And this is sort of a universal sign that says that they're having symptoms with their shoulder and that the weight lifting is either the cause or is an aggravation to the pain in the shoulder. It's sort of a universal symbol. You'll see somebody rotating their arm around, and that tells you that their shoulder is hurting. But then that person will then commence their next set of exercise and continue on unimpeded in that exercise and continue with a set of bench press or shoulder press or bicep curls or what have you with their full strength. And even though the shoulder is sore and they're having symptoms in the shoulder, whatever symptoms they are, they're not sufficient to interfere with the activity of lifting weights. Sure, there's symptoms there. Sure, there may be pain, soreness, symptoms, aggravation. The symptoms are getting their attention and crying for attention, but the symptoms do not interfere with the ability to lift weights. In that sense, those symptoms qualify as minimal pain only. And many times the symptoms that our examinees describe qualify only as minimal pain because the pain actually does not significantly interfere with activity. Okay, now the next level of pain that's described in the 2001 Physician's Guide, and this is a more impairing and impactful type of pain, is known as slight pain. Now, slight pain causes some handicap in the performance of the activity. If you look at this picture, this woman is clearly describing or depicting pain, probably headache pain. And you can tell that her forehead is furrowed, her eyes don't look good, she's not smiling. and she's doing a universal symbol of I have pain in my temples or side of my head. This is a universal sign for headache pain. Now, this person, probably with this level of pain, has some handicap in the performance of activity. So let's talk about the activity. Let's say she's a secretary. She's probably having a difficult time handling her phone calls. She's having a difficult time concentrating on her customer or client because she's mostly focused on herself and her headache pain. She's having difficulty completing her transcription and her Word document processing, and she's not doing well, and she's having trouble performing activity. She can still do activity, but there's some handicap in the performance of the activity. Well, what about the guy at the gym with the sore shoulder? Now, when the minimal pain advances to slight pain, then the guy at the gym would say things like, well, I need to lighten up this weight. My shoulder is really sore. Or I need to skip this exercise altogether because this exercise is hurting my shoulder. And there's some handicap in the performance of the activity. The guy in the gym may be able to do the exercise, but he has to modify the range of motion, perhaps using only a partial range of motion as opposed to a full range of motion. In other words, there's some handicap in the performance of the activity. Let's think about a person who has rolled their ankle and suffered a sprain of the lateral ankle ligaments. How can we tell whether their pain is minimal pain or slight pain? Or let me ask you this question. How can we gauge the severity of any sprain of the lateral ankle ligaments? Well, a person with slight pain is going to have some handicap in the performance of activity. In this case, the activity would be weight bearing and or walking, or perhaps even running. A person with minimal pain will have pain in the lateral ankle, but the pain does not interfere with their ability to walk. They have normal gait, they're able to run, they're able to carry on fully functional even in the presence of pain. That's a minimal pain. A slight pain, we're going to see some form of a limp. We're going to see some limp. In chapter 17, they refer to that as an antalgic gait. Antalgic gait. And isn't that what a limp is? A limp is a manifestation, is evidence of slight pain. It's an evasive action away from pain. A limp is some handicap in the performance of the activity of walking. So we can use these signs, these signs of handicap, these signs of evasive action, these signs of antalgia, these signs of limitation in the ability to uninhibitedly perform activity. Okay? Well, what's the next level of pain? Now, severe pain. This is an example of an examinee who's having myocardial infarction, and in this case, the pain is severe. Now, by definition, severe pain is pain that precludes the activity. And if you've ever known anyone who was having a heart attack, or if you ever had a heart attack yourself, you know that the pain precludes all activity. It stops the person dead in their tracks. They clutch their chest or their left arm, and they can't do anything except writhe around in pain. And the numbers of activities that they cannot participate in basically is all inclusive. It includes all activity. So the pain is more interfering with activity, and the numbers of activities is exponentially greater as we go up this scale from minimal pain to slight pain to severe to moderate pain, and moderate pain to severe pain. Okay, so let's elaborate on these ideas a little bit more so that we're all fully versed and on the same page with these descriptions of pain, and then we'll talk about how to apply these descriptions of pain to our physical examination procedures. Okay, so now that you know the definitions of these pains, minimal pain, slight pain, moderate pain, and severe pain, never tell an injured worker, or any other person for that matter, that the pain that they're experiencing is minimal. And the reason is, when you're experiencing pain, it seems that our systems always default to either moderate pain or severe pain. And any husband who's ever had a cold or flu or felt just generally miserable will attest to the fact that when you're not feeling good and you're on the couch, boy, you just want everyone to know about it. You want them to know how terrible it is, how excruciating it is, how miserable it is, even though the pains, by definition, qualify only as minimal pain. And that's exactly the way our examinees are. They come in and they tell us that their pain is terrible. It's ruining their life. It's interfering with all their activities. They can't sleep. They can't have sex. They certainly don't want to hear from you that their pain is, quote unquote, minimal pain. Now, occasionally we're going to see examples of slight pain, and this is what we generally see most commonly in the qualified medical evaluation, and that is the pain causes some handicap in the performance of the activity that causes the pain. This means that the pain disadvantages the activity that causes the pain. So what would be some examples of this? Well, we talked earlier about the antalgic limp, where pain disadvantages the activity that causes the pain, which is weight-bearing or walking activities. Now, it's open to interpretation what qualifies as quote-unquote some handicap, but some handicap should be accompanied by some sort of outward, visible, objective alteration in the performance of the activity. And what we're looking for in the form of an outward, visible, objective alteration is we're looking for some sort of pain avoidance behavior, some sort of evasive action, some sort of muscular defense, some sort of the flexor withdrawal reflex. In the absence of some outward, visible, objective alteration in the activity, the pain simply qualifies as minimal pain only. It does not rise to the level of even a slight pain. Well, what about moderate pain? Well, many examinees in the workers' compensation system, and people in general, they'll tell you that the pain that they're having is moderate pain. Now, in the qualified medical evaluation, this amounts to examinees using numbers on the 0 to 10 scale, using numbers such as 7, such as an 8, such as maybe even high as a 9. They'll tell you that their pain is moderate. They won't push the envelope and say that the pain is severe. They report quote-unquote moderate pain because, number one, they're not aware of the definition of this term the way that we use it in the workers' compensation system, and we can't expect them to know the definitions of pain that we know and that we rely on. But the second reason that they use the word moderate when describing their pain is because moderate is a description of pain that can be safely used by the lay person, because it does not appear to be overly exaggerated. It appears to be within the realm of what we would consider to be the range of pain that people commonly experience given the history and the mechanism of injury suffered by our examinee as he sits in front of us. In other words, the pain is not severe, it's not excruciating, it's not awful, it's not life-wrecking. In other words, it's not these disastrous and devastating terms, because they want to appear genuine. They want to appear not overly exaggerated, and so they'll use words such as moderate pain. So moderate pain is something that you as the doctor need to corroborate with your opinions and conclusions. Because remember, by definition, moderate pain is pain that causes a marked handicap in the performance of activity. And if your examinee does not demonstrate marked handicap, then even though moderate is the way they describe their pain actually does not rise to the level that qualifies as a moderate pain. Now, we rarely see examinees in severe pain, because severe pain is something that we see more in the acute setting than in the chronic setting. But trust me, examinees, they will tell you that what they're experiencing is a severe pain. People in severe pain usually find themselves in the emergency room of hospitals, and they're usually on gurneys because the pain prevents all activity, including weight bearing, including standing, including carrying on conversation. And so we don't see examinees walking into their QME appointments in severe pain, even though many times examinees, not knowing these definitions, they will describe their pain as what seems to them or what they perceive to be as a severe pain. So we rarely see these types of examinees. So for our purposes, we can pretty much discount the severe pain category. Okay, so let's review these definitions of pain. Again, a minimal pain is a pain that causes no handicap in the performance of the activity. So let me give you an example. You're doing lumbar range of motion testing, and you ask the examinee to bend over and touch their toes so that you can do some measurements of lumbar flexion. As the examinee bends over to touch their toes, they scream out in pain, and they point to the L5-S1 articulation of their spine as the origin of the pain. And as they bend over to touch their toes, they let you know how severe and terrible the pain is. And they go, oh, 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 that hurts, oh, my back, as they lean over and touch their toes. Now, despite all the exclamations about the torturous nature of the pain, you can conclude that because the pain does not interfere with the ability to lean over and touch their toes, this is lumbar flexion. The activity is lumbar flexion. Because the pain does not interfere with the activity that causes the pain, which is lumbar flexion, you can conclude that this is a minimal pain only. It does not interfere with their ability to fully bend over and touch their toes. Now that's different from a slight pain. Slight pain causes some handicap in the performance of the activity. So the examinee bends over to touch their toes, they get down to a point below their knees, and they go, ah, oh, ooh, I'm having pain in my lumbar spine. And at this point, they're able to slowly walk down their legs, using their hands to walk down the tibia bones, thereby unweighting the lumbosacral spine. And they're able to touch the tops of their feet and then return to the starting position by walking their hands back up the tibia and back up the femurs until they get to the fully upright position. This is a form of a modified Miner's sign. So they're able to touch their toes, but there's obviously some handicap in the performance of the activity. In this case, they need to use their hands to unweight the lumbar and sacral spine at the extreme of the lumbar flexion position. So they have some handicap. This is a true objective finding on physical examination. Okay, there's some interference with the activity. A moderate pain is a marked handicap in the performance of the activity. So this would be an examinee who would be limited in lumbar range of motion, may be able to bend over only to a point of touching their fingertips to their knees, or perhaps to the mid-shin, at which point they abort the maneuver, because to go any lower is simply not possible because the pain increases to a point that precludes further lumbar flexion. And then severe pain. Severe pain is a person who cannot do lumbar flexion at all. The pain precludes the activity. And I don't know if you've ever had an acute lumbosacral sprain strain injury. I have. And if you've ever had an acute lumbosacral sprain strain injury, you know, or you remember, that there's lumbar paraspinal muscle spasm. And that muscle spasm, the purpose of that muscle spasm is to prevent motion of the lumbar vertebrae. And if you move in such a way that you provoke inadvertent motion of the lumbar vertebrae, that spasm will kick in and will tell you, it will tell you to not do that motion again, because it gives you a sharp pain that precludes the motion, which is motion of the lumbar vertebrae. That spasm is there to prevent motion of the vertebrae, and we need motion of the vertebrae in order to perform the movement of lumbar flexion. So that would be an example of severe pain. Okay, so doctors, we can use these descriptions of pain throughout our interview and physical examination with the examinee. We want to always be thinking about the level of pain that the examinee is reporting, both in their descriptions of pain and also in their performance on physical examination. One example that we alluded to is the examinee who reports pain on spinal range of motion. A good question for you as the doctor is, does the pain interfere with full range of motion or not? If it does not interfere with full range of motion, that tells you that that's a minimal pain. That's a minimal pain. And I'm jumping the gun here slightly, but just to move forward into the AMA guides, the AMA guides tell us that minimal pain, meaning pain that does not interfere with activity, does not qualify for a permanent impairment rating. In other words, you could have a lumbar spine that has the worst accident in the world, the worst injury in the world, maybe fell from the fifth story scaffold, has the worst looking x-rays in the world, the worst looking MRI in the world, and yet when the person attempts to do lumbar flexion range of motion maneuvers, they have full range of motion. That does not qualify as a permanent impairment rating because the pain does not interfere with activity. It's a minimal pain only. So you want to always be asking yourself, is that a minimal pain? Is that a slight pain? Let me give you another example. And we'll touch on this more as we get into activities of daily living. When the examinee is describing the impact of their pain on their activities of daily living, you want to always question them and always inquire to determine the nature of the limitation and determine whether the limitation is due to minimal pain, whether it's due to slight pain, whether it's due to moderate pain, or whether it's due to severe pain. So let me give you an example. You're questioning the examinee on their activities of daily living, and you ask the examinee, are you able to use the bathroom for urination and defecation? This is one of the categories of activities of daily living described in the AMA guides. This is under self-care and personal hygiene. So you ask them, are you able to use the bathroom for urination and defecation. And so the examinee says, let's say this is a female examinee. She says, yes, I can. However, I have a lot of limitation with this because when I sit down on the toilet, I have pain with sitting. It's difficult to get up and down off of the toilet. And also, when I wipe myself, I have pain with twisting around and reaching to wipe myself. Now, many doctors would report this in their report as the following. They would say something such as, quote, limited in self-care and personal hygiene, specifically activities of urinating and defecating are limited due to pain. In other words, the doctor describes the limitation exactly as it was given to him by the examinee, without pursuing that limitation to see if indeed that activity has no handicap, some handicap, marked handicap, or whether the activity is precluded. So what I suggest is that you follow your questioning, you follow up question the examinee to determine if indeed there's a limitation with the activity. The examinee typically is responding, telling you that indeed there's pain with the activity, pain, but not necessarily whether or not the activity is limited. So the line of questioning would go as follows. Oh, okay, I understand, Mrs. Jones. So you say when you use the toilet for urinating and defecating, you have pain. And when you reach around to wipe yourself, it's hard to do because of pain in your lower back. Is that correct? And they will say, yes, that's correct. The next question is, okay, Mrs. Jones, I understand. But let me ask you, can you do it? Or is this something that you need to get help with? In other words, does your husband have to help you get off and on the toilet? Does your husband have to help you clean up and wipe yourself? Or is this something that you do yourself? And most typically they'll respond and they'll say, oh, well, I mean, this is something I do myself. I mean, no, I don't need help, but I have a lot of pain when I do it. This qualifies as a minimal pain. As a minimal pain. Now, do we know whether or not they actually have pain with this activity? No. It's like we said earlier, we cannot feel what another person feels. However, we simply observe the activity, which is using the toilet and wiping oneself. We observe the activity and see if the activity is limited. And she said that she gets up and down off the toilet. It's difficult, but she can do it. And she can wipe up and clean up herself. It's difficult, but she can do it. And so in that sense, the pain, however terrible it is, does not interfere with the activity. Let me give you another example. As the examinee, Mrs. Jones, can you go up and down stairs? And they say, oh boy, I have a lot of pain with stairs. I have a lot of pain with stairs. I have to use the handrail going up. I have to use the handrail going down. And when I'm coming down, I have to come down one step at a time because it's simply too painful to do two steps or one step with each foot. So, doctor, always ask yourself, what's truly objective here? What is the level of pain that the examinee is truly having? What are the truly objective findings here? So the next line of questioning might be something similar to the following. And I'm just making this up. You can come up with your own line of questioning, but this is an example of how you would follow up the examinee's descriptions. You might ask, okay, I understand. So you have some difficulty going up and down stairs. Is that correct? Yes, that's correct. Okay, well, let me ask you, can you go up and down stairs? Can you go up and down stairs? Or do you have to use the elevator or the escalator? And they might say, oh, well, I mean, I can go up and down stairs. It's just like I said, I have to use the handrail, and it's difficult. Next line of questioning might be, okay, I understand it's difficult. Let me ask you, do you have stairs at home? And the examinee might say, well, yes, we have stairs at home. Is your bedroom upstairs? Yes, my bedroom's upstairs. Do you go up and down the stairs to your bedroom? Well, yes, I do. Are there stairs leading from the street to your house? Yes, there are. Can you go up and down the stairs to get into the house? Yes, I can, but it's difficult. What's truly objective here is the examinee, in their own words, can do it. They're telling you that they can do it. They live in a home where they have to go up and down the stairs to get to their bedroom. Now, this is a pain, however severe and terrible it is, that qualifies as only minimal pain, or perhaps at the most slight pain, if you're convinced that indeed there's some handicap in the performance of the activity. The point of this exercise is for you to follow up your questioning and come to some determination that you're comfortable with in your own mind, doctor, as to the level of pain that the examinee is truly suffering, and the level of impact on their activities that they're truly experiencing. Don't simply settle for the examinee's descriptions of their pain or their handicap, because they will always overstate their handicap. And we'll talk a little bit more about that overstatement when we get into section number 4 of this program on symptom magnification and malingering. Okay, so let's move on now to section number 2, and let's talk about inconsistencies between the medical records and the findings on the QME interview. Okay, so let's start transitioning now into the QME interview and talk about activities of daily living and other assessments of activity. But before we get into that, let's just reiterate the theme of the material so far, and that is that we can expect our examinees to misdescribe their symptoms and the severity of their symptoms because, of course, they're not versed in the technical definitions that we use in the workers' compensation system, so they'll tend to overstate and over-exaggerate their level of their pain. They'll use words such as moderate pain and words such as severe pain. So this is not something that we hold against them. We simply realize that they're not versed in the definitions that we are familiar with. And also remember from our earlier discussion, it's going to be more the emotional aspect than the sensory aspect that they will be communicating to us about. You can expect your examinees to be quite emotional when they describe their situation, and specifically when they describe to you their pain and the impact of that pain on their activities of daily living. So let's elaborate a little bit more on pain and its impact on activity.